My background is in competitive climbing. I grew up here in Canmore, and I trained over at the Vision Climbing Gym. For those of you that still remember that, it was the gym before Elevation Site. This top left photo is us, my team, when I was on the youth national team, and this is from Bulgaria. For those of you that follow competition climbing, you may recognize a couple faces. There's Tom, there's Vicky Weldon. Some of you may know Mike Doyle, climbing mentality, and with Austin Fitz. Which is awesome. And then on the left-hand side, these are a few of the national teams that I've coached over the last couple of years. So the top one is in Arco, Italy. And the bottom two are the most recent. We were in Dallas, Texas for the Youth World Cup. All right, so here's what we're going to talk about today. I'll be talking about the most common climbing injuries. So we may not hit everything that all of you have experienced, but if you have questions about other injuries at the end, then by all means throw them out and we'll discuss where we can. And I've sort of categorized them by youth and adults because they do have distinct injury patterns. We'll talk about the why and how these injuries occur, and then just a snapshot look at treatment. So if I was seeing these things in the clinic, what kinds of things we might do for treatment. And then the most important thing, injury prevention, of course. So we'll go through a bit of a screening, warm up. And these are the things that, like I said, are most important because they allow us to reduce the risk of injury, mitigate that injury, or at least reduce time lost from sport when you do have those injuries. And so as we go, please throw out questions. You don't have to save them to the end. You can make this sort of interactive if you like. So these injuries are mostly to do with sport climbing. So bouldering, those injuries sustained in like mountaineering and alpinism, I don't touch on as much. They're sort of a different category. Now, injury rates in sport climbing are about 3 per 1,000 participation hours. And I know that may not have that much meaning just to hear it, but if we compare that rate to other sports, it's actually very similar to injury rates in soccer and hockey, which is interesting because those sports are contact and collision sports. So you might expect that they have a higher injury risk, but climbing rates are very similar. Obviously different types of injuries, but interesting to know. So who here, I want to ask, who here has had a climbing injury? Yeah. And who here, keep your hand up if it's affected you in the last year. And then keep your hand up if you're experiencing something now that's affecting your life. Yeah. So kind of makes sense that the climbing injuries are caught. That's why you guys are on here obviously right now. It's my friend Kat in South Africa. She's awesome. Nope. Okay, next question. What do you think are the most common climbing injuries? And again, we're talking about sport climbing, bouldering, speed climbing in adults. Like your tendon issues,
Shoulders,
sprains, shoulders, fingers, pulleys. Somebody said pulleys. Is that? All right. Whoever said pulley injuries is correct for number 1. Nice. So, and whoever said fingers, you're right for the top 3.
Yeah.
Yeah. So pulley injuries are number 1. So here's that pulley injury. Yeah. What's a pulley? Okay, we'll get to that. I have slides and slides on that. Don't worry. Flexor tendon. Yeah, I'm going to talk about all of these in a little more detail. Don't worry. Flexor tendon tenosynovitis. So essentially that's overuse of the flexor tendon, which come from the forearm here and split into each finger. Some of you might have heard of it as flexor tendonitis, or strain sometimes, but this is the real nomenclature that we should use. Capsulitis, so some of you have had those really sore fat knuckles before. That's capsulitis. And then knee injuries as a whole group is number 4. So we'll get into each of these in a little bit more depth. Okay, next question. I was kind of hoping some teenagers would be here. Are there any coaches here? Any climbing coaches? No, okay. Parents of climbers? No, okay, you guys don't care about this at all. Okay, what's that? Muscle strains? Yes. All right, so number 1 for youth climbers is actually growth plate injury with fingers, which is a bad one, right? And then capsulitis, which was, if you recall, number 3 for adults. So we cross over a little bit. All right, so I figured I'd just talk about the youth injuries and get them out of the way since you guys weren't here for that, I was guessing. So don't look at this slide too closely. I know it's pretty busy, but the key points of this are just to know that growth plates are the growth centers of bone at the end of each long bone. It's essentially cartilage, and with too much stress, injuries occur at the weakest length, which for kids happens to be that cartilage where bone is growing. And this is what they might look like if you see them, or when I see them in the clinic or as a coach. So it's pretty obvious that you have some swelling going on through one of the knuckles. Typically it's in the middle finger. A lot of these injuries actually really common in the middle and 4th finger and that first knuckle there. So it might be tender on the back of the finger. There may be swelling that's reducing range of motion. And I have a slide later on this too, but my quick and dirty metric for swelling in the fingers is flattening the back of the hand and then trying to touch fingertips to palm. Now, some people, depending on your age and previous injury history and genetics and all that, you might not be able to touch, but if you have any symmetry or pain, then it's kind of a good comparison over time. So this is most common in males, and it happens around peak height velocity, which is when an adolescent is growing their fastest. So typically this will be the 11 to 13-year-old girls or the 13 to 15-year-old boys that climb or train a lot when they're growing really, really fast. And this interesting statistic that I'm always surprised by, but it's supported really well in research, that 9 out of 10 children that have finger joint pain in one finger that goes on for a week despite rest actually have a fracture. So really interesting. Bad repercussions if not dealt with properly. So these guys need to go to the doctor pretty quick. And then we have a couple rules of thumb for risk factors. So if you're a youth climber that's training more than 4 days a week, or more hours per week than your age. So for example, if you're a 12-year-old that's climbing more than 12 hours a week, that puts you at very high risk of stress fractures. And minimum 2 months rest. That really sucks for a lot of kids to stop being with the team or doing their activity for that long. So we try and prevent that before it happens. Okay, moving on. So capsulitis. If you recall, this was number 3 for adults. So I think this is one that's not really identified very commonly because sore fat knuckles aren't really seen as an injury for a lot of people. But if you don't rest from it, if you don't deal with it properly, it can kind of snowball and turn into, you know, a long-term thing later on, or maybe arthritis, etc. And this looks very similar to the last photo, doesn't it, of this stress fracture. So if it were a child with this, I would still send it along pretty quickly to the doctor. And again, common in that middle finger, that first joint, common from hyperflexion. So crack climbing, for example, will set you up for this sometime. And then repetitive movements as well. So if you're projecting, continually gripping and hyperextending or hyperflexing the same fingers and loading them a lot over time, many times, then that could be one reason that you develop this. And so when I see them in the clinic, often there's no sudden mechanism. With pulleys, for example, some people will tell you that they had a sudden foot slip or a dry fire, and that'll bring on immediate pain or a pop. That's not usually the case with this. This just comes on over time. Your knuckle gets fatter and more sore. So, and this is what I was talking about before. So repetitive movement patterns with projecting, for example, recent volume or intensity increases. And that those are all things that add into the overuse. So that's why it's good to have variety. That's why it's good to have proper rest time. And we'll talk about that a little bit later when we talk about the injury prevention. And sometimes these can, there can be avulsion fractures or something that look like this. So sometimes it's worth sending them for imaging anyway. Sending them, as if you're sending them. Go into your doctor. Okay, and then if somebody came into the clinic with this injury, what would I do? So traction actually helps hugely with these things, and it's the simplest thing in the world. You just pull on your finger and then crack it. And it just gaps the joint and allows some of that joint fluid to come in, provide nutrients to the joint. Sometimes that circulation will help circulate out some inflammation or swelling that's in there, metabolic waste or substrates. So that's one of the easiest things you can do if you feel that sore knuckle coming on from that knuckle. Traction is easy and safe. Typically, I'll look at forearm extensors and flexors and release them, because tension through the muscles in the forearm, as some of you know, those muscles come down and go into all the fingers. So tension in those muscles creates compression and tension in the hand. And so releasing those muscles provides some slack to the system. So it can help decompress those joints and again, provide that space for the circulation to come in and help heal. The intrinsic hand muscles, same thing. So that's just all the muscles that are actually in the hand. And the kinetic chain. So what I mean by that is I'll always assess at least from the neck and shoulder down, because sometimes poor mechanics of the shoulder affect everything going on down the chain. And I'll talk about that a little bit later on. And tendon gliding. So with any finger thing, I pretty much always give tendon gliding because it's really easy as well. Which, yeah, and I've seen some of you doing it already. We're essentially just taking our fingers through their entire range of motion. And this is a good thing to do as part of your warm-up, as part of your cool down throughout your day. And it just allows the tendons in the fingers to slide and glide past the pulleys and past all the structures as they should, because we don't always get that full movement throughout our day. And it lubricates the track, etc. And then because fingers get so little blood flow on their own, there's actually no muscle values in fingers. They tend to heal a little bit slower than, say, your forearm muscle or anything that is, nice and juicy and get lots of blood flow. So self-massage is one way to bring in some circulation. Contrast baths are another way. But I have had people go overboard with this. So some people, when they have a finger injury, will sit there unconsciously and just rub it all day. And that actually can keep up the inflammation. So careful with that piece. And then hangboarding. Hangboarding is an excellent tool for any finger rehab as long as it's far enough along that you're not further injuring or creating inflammation. But it's a really good way to load in a healthy way all the tissues in the fingers. And in a really controlled way. So it's very static. Don't have to have feet off the ground, on the ground. So it can be really braided. And a good way to progress back to climbing. Any questions, you guys?
Can you use splinting for traction?
No.
Because I know some therapists.
Yeah, definitely. I think it could for sure. I think in more acute injuries, if there's a lot of inflammation and lots of function going on, then for sure. I haven't seen it with capsulitis, but I don't think it'd get that idea. Yeah. And that way you could get some, longer term traction. But typically with my patients, we just do the easy method of self-traction. But yeah, I think it'd be an awesome idea.
Is that a preventative thing as well? Will that help to prevent injuries?
I don't think it's a bad idea. I mean, it does help, create that circulation and therefore keep that joint healthy. So yeah, that'd be awesome.
We had a question from someone online. Maureen is asking about tennis elbow in terms of whether it happens, that tendinopathy happens with climbers inclining.
Yes. Yeah, I see. And so tennis elbow isn't something that's in the top 4, but I see it super commonly. And same thing with shoulders. Shoulder injuries like rotator cuffs, even labrum tears, very common in climbers. And that, again, has to do with the kinetic chain. So I can get into this a little bit now, but I have a good slide on it later on. Typically, what I see in movement patterns with climbers is that we all do this. When we're feeling tired and whatnot, our shoulder starts to come forward and we get to that chicken wing position, which is okay if we're doing it every once in a while when we're red pointing a root. But it's for those climbers that becomes their normal pattern. Then it becomes that mechanism of overuse. And so when that shoulder comes forward, it puts the rotator cuff on stretch for one. It puts stress at the front of the shoulder joint. And so either of those things can start to get injured from repetitive or a fall in this position is bad too. But then you'll also notice that my elbow starts to kick back. And so in order to contact the wall, maybe my wrist is extended. Or maybe it's even caught to the side. But that creates a lot of stress through that elbow. And so it may manifest as lateral elbow tendonitis, medial elbow tendonitis, so your tennis and golfer's elbow, or because now the wrist is extended and all those tendons and the fingers are stretched and stressed, it may be the pulley injury that manifests, it may be that flexor tendonitis. And so that's the reason that I always look at the kinetic chain. And in an ideal world, I'd watch people climb too, because a lot of the time I do have a pull-up bar and some hangboarding stuff in the clinic. And so I'll get them to engage and I'll see, you know, that kind of pattern happening. So I suspect that's what they're doing climbing. And yeah, like I said, it can manifest in the shoulder, elbow, wrist, hand.
How could you train yourself to not get in that position and you're not even aware that you're doing it while you're climbing?
Yeah.
Is there any rules of thumb that you could get to, you know?
Absolutely. So maybe I'll delay that question until I get to the warm-up piece, because that's a really good way to sort of train that routine or train that motor program, let's say, while you're climbing. And also having a friend watch you videoing it, you'll be able to tell, but I'll show a couple photos later that I think might help a little bit with that. And if I don't answer it later, then ask me again. Okay. Moving on, so the flexor tenosynovitis. So like I said, those are the sheets of those finger tendons. Yeah, you can see like so hyperextended, right? But that's how we climb. So with these, there's often no traumatic mechanism, being that sudden foot slip, the dry fire. But this is when that tenderness in your fingers starts to develop. You know, the one at the base of your finger, it's getting sore, the same finger every time you climb. And once again, you may have that reduced range of motion, some swelling through one of your fingers. And again, and I'm repeating this on most of the slides, but that's intentional. Just so that you think about, am I really repeating movement patterns? Am I trying the same route with the same crux over and over and over every session? Or have I recently changed up my program and I've all of a sudden increased the volume or the intensity? So thinking about why aches and pains are starting to come on before they turn into something like this. And then when I see them in the clinic, and I see somebody with finger pain like this, I would typically release for their forearm flexors, again, to put the slack in the system. The hand muscles, we're assessing that kinetic chain and hopefully their shoulder movement and elbow position. And many of the same things that I touched on with the capsulitis.
You say release that the dry needling, is that the saw?
Great question. Yeah. So any of the above. There are so many tools. I use needling a lot. I use massage a lot. I use the massage gun. When you're at home, many of you probably have the arm aid. That's an excellent tool. If you have a lacrosse ball, releasing the forearm extensors can be really nice up against the wall. Having a partner do it for you. Yeah, great question. Okay, and now the topic most of you wanted to talk about, so pulleys. So here's sort of your textbook diagram of the pulleys. This would be where your palm starts here. So most commonly injured is the A2 and then the A4. So here's another little diagram. The A2 pulley is the one at the base of your finger here. And for those of you that have had a pulley injury, the pain was probably more on one side than the other. And then A4 is the one sort of in the middle bone there, in the middle pad. And again, middle and ring fingers are most commonly injured. And the reason that the A2 and the A4 are usually injured compared to the other ones is, one, they attach to bone, which is really unforgiving, whereas the other one's attached to more elastic tissue of the joint capsule, so the molar plate. So it just has more give. And two, when we're crimping compared to open hand, crimping increases the force through that A2 pulley by almost 32 times. and through the A4 pulley by 4 times. So if you can imagine, if your pulleys, you know, aren't under stress, and then as soon as you get to that current position and load it, there's 31 and a half times the force. That's crazy. Okay. So this is where we typically have that sudden foot slip, the pop, the dry fire, and then sudden pain. You're great. Crossed out, yeah. Yeah. But most people don't know that this does come from overuse in the first place. So it typically tends to be sort of the straw that broke the camel's back, in that a lot of those mechanics, so again, coming back to that kinetic chain, maybe you're projecting something over and over without resting, or maybe you're climbing with poor mechanics and loading that pulley, overloading that pulley, I should say, and then something overloads it. And that's when you get that pop, that pain, but it's hard to notice leading up because it typically is painless until it actually gets injured fully.
Sorry, what is dry fire? I've never been.
Oh, dry fire is like you're grabbing a hold, moving, and then all of a sudden you slip off without knowing that it's coming. Is that a good description?
The one-handed clap.
Yeah, one-handed.
I like that.
Okay, so don't look too closely at this, but it's just to give you an idea of healing timelines. So pulleys can be anywhere from like 4 weeks to 6 months or longer. So it really depends on which pulley is injured, how many pulleys are injured. If it's fully ruptured, it can need surgery. And only those that have multiple pulley ruptures will need surgery. So by and large, these are treated conservatively. Often, now all the time, if there is a full pulley rupture, we'll splint it. And I have a picture of that. And for those of you that have had a pulley injury, how long do you feel like it affected you? Like how many weeks or months?
With tape or without tape?
Any amount of pain while climbing where you noticed it?
So
Tape or no tape?
Oh. Yeah, months.
Months, right? Yeah. So typically, even once these are fully healed, there will be ongoing pain. And this is where it's really important to attend physio, because some of that pain isn't always from the pulley, it's from the related structures. Sometimes you start to develop the flexor tenosynovitis as well. And then often muscles start to compensate, tighten up to protect it, and can refer pain as well. So it's not always just the pulley. And that's what this splint looks like. This is actually my husband's hand who tore his pulley, flipping off a door, like dry firing, grabbing a heavy door. And so whether or not you have a full tear and you need to splint it, H-taping is what you'll do after that. Or if it's not fully ruptured, if I see someone in the clinic, I may get them to H-tape for all daily activities for at least a couple of weeks. And H-taping, I actually have a slide on it later on if you're interested, but it's a specific type of taping that we do for pulleys, different than the figure-8 tape job and different than buddy taping. Who here doesn't know what H-taping is? Okay, I'll definitely go over it later on then. Yeah, I should have put that slide right here, but. Okay, and then a lot of this is repetitive, right? So we're still gonna release the forearm muscles, massage them or needle them, and a lot of that you can do on your own, obviously. It's not just a physio thing. Well, the needling is, but
Why is splint just a certain differential?
so the special thing about these splints is that they have a gap on either side for the neurovascular bundle, which means that the nerve and the artery and the vein that go through the blood vessels have space. With circumferential taping, you can't get as much pressure without cutting off the circulation.
So this is giving a lot of pressure.
Exactly. Yeah. Yeah, and it's going to be pretty tight and like a little bit uncomfortable, unfortunately. Again, we have the tendon gliding as long as it's not painful. So some of that may be delayed a little bit, depending. Self-massage, contrast that. Traction is more to do with the joint, but I find that the joint starts to become affected when the finger is unable to move properly. So it's a piece that I've actually been adding into fully rehab recently because I found that it actually makes quite the difference. And then again, hangboarding in the later stages is an awesome tool. Other than the H taping, any questions about pulleys? Cool.
Does collagen help at all?
Oh yeah, good question. That is not my area of expertise. I'll refer you to your Ellie. I think there's some research, but yeah, sorry. It's not my area. You're gonna have to go about that. This is Natalia from the US.
She had a knee injury.
And she actually didn't become injured here. It's crazy. She just has amazing hip range of motion, but it looks like she should be injured. So the injuries are increasing year after year with climbing, and that's mostly because of bouldering. These days, it's very dynamic. It has that sort of parkour nature. And so the injuries that are sustained are the MCL, so the ligament that provides stability on the inside of the knee, and the medial meniscus, when it's the drop knee position, you can see why that's stressed. We have the LCL, or the lateral collateral ligament, providing stability on the outside of the knee, and the hamstring with heel hooking. There's a lot of torque that goes into the knee in that position, especially once you get all your body weight on top of it. And then obviously injuries from falls, so meniscus, ACL, any number of things. Who's had a knee injury from climbing? Yeah, okay, not crazy common, but yeah. And so the important key message is that we can't ignore the lower body. We still have to warm up legs, strengthening, working on range of motion so that when we get to these positions, our body is able to handle it. And that's what I just said, yeah. And it improves performance too, right? I think one of the things that I really want to express that all of this injury prevention stuff isn't just so that you can keep climbing, it's so that it'll increase your performance too. The more healthy you are, the better mobility, the stronger you are, the better a climber you'll be too. Okay, well, I just gave a bunch of hands. Oh, question.
Any common technical errors that you know about that you're looking that can lead to knee pain?
That's a tough one because I know there's actually a research paper that says that you should always keep your toe in line and never rotate through your tibia. And yes, if you can do that, then it will reduce knee injuries because rotating through your tibia and then flexing and putting force through that increases the shear. I've definitely tore my LCL doing that twice. But if you ask any climber, it's not really functional. To lock that heel in often, you really do have to rotate. So my best advice would be work on the strength, your hamstrings a lot. Work on your inner range strength so that when your knee is fully flexed, strengthen that position, strengthen those rotations, and climb only to a level that you feel like you can really control and be stable. But yeah, these things happen. So the technique piece is one thing, and then in reality, if you can just be strong enough and mitigate that risk, then that'll help too.
Say strength and hamstrings, like deadlifts, or if there's something else that would be better.
There's a million exercises. Deadlifts are an awesome one. With heel hooking, like I said, we tend to be in a really flexed position. So anything where you're sort of pulling that heel in toward your bum and working that sort of closed angle will help a lot. What else? Yeah.
The deep squats, maybe, you know?
Like
Just call hamstring throws.
yeah. And to add to that, hip mobility is going to help with that too. So the more weight you can get through the hip and take it there, the less it'll hyperload your knee, right? Yeah, really good question. Okay, other than the things I just mentioned, what do you all do for injury prevention? Yeah. What do you think you should do?
Oh, warm up.
Strength training.
Strength training, yep. That.
Flexibility.
Mobility, yep. Nice. Yes, so rubber warm up. And it's helpful to do a warm up specific to the activity that you're doing. So a speed climbing warm-up's not going to look the same as a bouldering warm-up, which won't look the same as, you know, a lead climbing warm-up. I think just to provide a couple of examples with bouldering, for example, and speed climbing especially, I make sure there's a lot of leg warm-up, jumping even, because you want to be able to land and have your body, your hips, your knees, your ankles ready for that load before you're super loading it. Yeah, moving down to the second point, self-screening for injury. We'll go through that in a sec. Strength and mobility, plan rest days, pain warning, proper fueling, sleep, etc. There's a million things. And as I mentioned before, all of those things are going to make you a better climber, not just prevent injury. So I'm hoping to sell it that way. Okay, let's talk about the self-screening first, and then we'll talk about the warm-up piece later on. So we'll go through a quick finger assessment, and this is something that you can all do as part of your warm-up. It should take 60 seconds or less. We'll talk about that swelling measure a little bit, and then we'll go through a shoulder self-assessment too. So I encourage you to participate as we go so that you can figure out what kinds of things your body is feeling at the moment. Okay, so here's what I do as part of my warm-up. I check each joint for tenderness at the knuckle. So what I do, I usually skip this one because it's less commonly injured, but it's certainly not a bad thing to have it participate to. I squeeze the sides of one knuckle, and then I squeeze the top and bottom just enough to blanch your fingernails. And then think to yourself, do I have pain? Yes or no? If you do, log it in the back of your brain. Maybe it's just today, maybe it'll go away after warm up. But keep it there just in case day after day you feel it and more you feel it. And then move down to the next knuckle, squeeze, squeeze, next finger, squeeze, squeeze. And down. And then we keep going. And then I check for pulley and tendon tenderness. So I should have written flexor tendon there too. But basically, I go to the base of each finger and I kind of rub on each side and right in the middle. Yeah, don't make me do this. I check for tenderness there, and then I go to the middle knuckle where that A4 pulley is. And I feel in there. Does it feel different than my last session?
Nani, they all hurt.
Did you just fun? Okay. Check it again tomorrow. Yep, good. And then here's a quick way to stretch the points a little bit. Push your thumb into the tip of your finger. Do that with each finger. Do you have pain? Is it in the area of a pulley or a tendon? Log that in the back of your brain. And then pull against each finger, and this one stresses again the pulley right on the tip of each finger. The pulley is intended. Does that bother you? Does it feel the same on both sides or different? Log it in the back of your brain. And then tendon glides. Does the finger that you just felt the pain with feel pain with the tendon glides? And then as you're doing the tendon glides, this is a good time to do that swelling measure. And so some of you are doing this. What you want to do is try to flatten that back knuckle. And now it may be normal for you to have some fingers away. If you don't have pain and that's the way it always is, then you may not have any problems in your fingers. But take note of any asymmetries from side to side, pain as you do this, any changes from day to day. And in the clinic,
Sorry,
oh,
can you stretch the capsule, like, you know, if they don't touch and then you can, like, they don't meet, and then you can get a bit more, I don't know.
yes, but typically capsules and connective tissue like that, you need that low load long duration. So it would take quite a bit of time for you to stretch it. And I think doing that would probably create some of that hyperflexion that puts you at a bit of risk for capsulitis. So I probably wouldn't bother. That you'd have to strike that perfect balance. I know. Yep. So in the clinic, I do tend to measure it for injuries if it's not touching, so that we can gauge change over time. And it's not an exact science, obviously, I'm just measuring from my comp, but for change over time, it's really good. Okay, so all of that took you maybe 60 seconds. Okay, we're gonna do this too. So, yeah, if you need to stand up, you can, or you can try to sit straight in your chair. Everybody, bring one arm over and one arm under. Just see how close are you to touching. Please not if you have any Yeah. Okay. If you have any pain, don't push into it. Don't try and get one over it. And then switch. What does the other side feel like? Now, probably on the second side, it'll be your non-dominant side, so you may have less mobility. That's pretty normal. It's pretty normal for our non-dominant side to have less, our dominant hand to have less mobility going this way. Just because that's stronger, more developed. Although in an ideal world, we would have even mobility side to side and there would be no pain. So take note, if you have pain in this position, it's one thing. If you have a little bit of tightness and lack of mobility on one side, that's another thing. And it could be more normal. It doesn't necessarily set you up for injury, but it may also be something to work on. Okay. And this is another one. You may do each warm up that you do for climbing, or you may do it once a week or every couple of weeks. Now, I think we'll just stay sitting, but pretend you have a wall behind you. And what you're going to do is glue your spine to the wall so that you're not hyperextending through the spine. So core is nice and engaged, elbows nice and straight, and then lift one arm overhead. And be honest, keep that elbow straight. Stop when you feel like you can't go any further. Good. Now, here is when, so this is my good side, just so you know. And I was totally holding my breath and taking the photo right at the second that I achieved it. My spine is straight and I have a fairly straight line. Okay, now try your other side. Don't push into any pain. I'll try that side. Okay, here's my left good side. So I still took a few photos and took the one that was best, but I am hyperextending through my spine. I'm trying to compensate. And so take note of that. Take note of any pain or pinching that you have. Don't push into it. But that may be something to work on. So for myself, I know I have a cranky right shoulder and I should be working on that mobility. But you can imagine why this is important for climbing, right? So, I mean, a lot of the time it won't matter too much because we tend to be kind of hanging with our arm at an angle anyway. But for certain moves, you really want that full overhead mobility. Otherwise, you're going to compensate through something. And you won't be able to have your core fully engaged. You don't have to extend through the spine. And for things like pull-ups and hangboarding, if you're doing that, that does tend to be a lot more straight overhead. So really, if you're not getting fully overhead, you have no business hanging there. Then you don't have the mobility, and then you're loading it. Okay, here's the next one. Oh yeah, question.
Was with the last position, you said if you get into that position, you have to pay that patient, but what if you can't get into that position at all? Is that a sign of, like, I'm not even close.
Oh, this one.
Yeah.
So, yeah. Is it even on the points?
Yeah, it's even on the side.
Do you have pain with that? Yeah, so it may just be your body. It may be that you need to stretch certain muscles or work them, roll them with a roller. Or it may mean that you're tight because you need to strengthen certain rotations too. So that's something that is easier if somebody can help you assess it. But for the measure that you're doing as part of your warm-up, I would just log it in the back of your mind. If you have no pain, it's symmetrical, then I wouldn't be too worried about it. Yeah, but understand that if you get into some weird position, say you're Gastoning and you're getting into these kind of position, you may not have the strength and mobility in that extreme range to put in. So yeah, sometimes it's good to go get assessed what you do for that mobility, but I wouldn't worry about it on a daily basis. Okay, so this one will actually assess that rotation. So goal post position. So come to this cactus position. Now, can you get there and keep your shoulders? And this one's good to do against the wall because some of you are forward here. Ideally, you'd be back against the wall. Yeah, good. And some of you are also a little bit up here. So ideally, shoulders are down. Again, core is engaged, back's flat against the wall, so you're not extended. Now, glue your elbows in space. So don't let them drop. Keep your shoulders down as far away from your ears as you can get. And can you rotate forward? Can you get to level? Can you get a bit past that?
What should you have? 45.
So at least 90 degrees, if not a little bit. Yeah. So I think Lactose normal would be 45 degrees past that level.
What tends to limit internal revision?
So often it'll be tightness through the rotator cuff. Sometimes it'll be tightness through something in the shoulder girdle, being like pec or lat, that it's pulling the whole head of the shoulder forward. Yeah, mostly those.
Perfect.
And then the question is, why is the rotator cuff tight? Is it injury? Is it a weakness? Oh, and now I'm just making up my face. Okay, so this is where that shoulder engagement piece comes in that you were asking about earlier. So this is what we want the foundation of every climb to be, right? Really engaged in the shoulders. Many of you probably know climbers that climb like this too. Shoulders up to the ears and then pulling. So learning to do this scapular depression, we call it. So shoulder blades pulling down away from the ears. An isolated movement without the elbows coming down. So a lot of people do this movement. If we can isolate the shoulder blades, that'll make for really healthy shoulders in climbing. Because as I kind of mentioned before, the problems come when you start to pull through the arm before you've supported with the shoulder and lock the shoulder blade down. Because if we don't, then we have sort of one moving joint on top of another moving joint, and then it becomes very unstable. And then, as I mentioned, the rotator cuff is on stretch, and it's not meant to be. It's meant to just stabilize as we pull down. So always remember that, lock before you load. And so this is something I include in my warm-up, is sort of a set or two of scapular pulls, maybe with my feet on, maybe not. And then it's something that I exaggerate as I start to climb too. And I always mention this to the climbing teams as well. Nail down this motor program on the easy move in your warm-up when you can really think about it. So exaggerate that movement before you pull for every single move. And then on the harder routes, when you're actually doing your session or wet pointing, that motor program comes a little bit easier and it comes more unconsciously. And that's part of the whole reason we warm up, right? Is to get the proper motor programs going, the muscles connected to the brain, etc. Not just to warm up the muscles and tendons themselves. Make sense? Okay, cool. Let's go into warm up. So in my ideal world, we'd include all of these things. So cardio, balance, proprioception, nerve flexing, all of the mobility and stability, core engagement, the lower body prep I talked about, climbing, motor programs like I just talked about, and then 100 to 120 hand moves. And so we basically tried to do this with the junior team at one point, and it takes like an hour before you actually start your session. And over the year, we just saw diminishing returns because it's too much, right? So especially the kids would do 1 or 2 of each thing, and it wouldn't really be useful. So how can we make this more efficient and effective as well?
What's nerve flossing?
Nerve flossing. So in the upper body, we have 3 nerves that we essentially deal with coming down the arm. And the nerves can be put under pressure or tension, and they can, cause MS tingling, or they can sort of ramp up other injuries, so to speak. Sorry, I don't know who asked that question. And so nerve flossing or nerve gliding for the upper body kind of looks like this, where if we think about The nerves that come down the arm start in the neck, kind of bundle through the shoulder, and then split as they come down the arm. Nerve flossing looks like this for the median nerve. And if you guys want to try, you'll probably get to the point where you feel that like really uncomfortable stretch going on, shoulders down. That's your median nerve. Some of you may have done this. And then if you keep that shoulder down, flip that palm upside down, and do like the owl eyes thing, or Dr. Evil if you prefer. You'll start to feel that through your pinky. So that's your nerve tension. And then radial nerve I tend to ignore, but it's one. Most people don't have a problem with it. So I'll give everybody the nerve speech that I give patients. Nerves don't like to be compressed and they don't like to be stretched, but they love to slide and glide, and that lubricates their tract and calms down the nervous system locally. And so if somebody is having some nerve tension that may or may not be contributing to other injuries, I get them to do the nerve flossing. But different than a muscle stretch, you should feel nothing with this one. So if you're going to the point where you're feeling that really uncomfortable stretch or tingling every time, then you might actually be tensioning it. So flossing is just moving through that pain-free range and getting the nerve to slide and glide. That was a really involved answer to your question, but that's great. Okay, so to pare it down, here are the things that I think are most important to focus on. And the other things I'm not throwing out the window, but I feel like they can be incorporated into those three things. So like lower body prep, maybe you're doing it in your cardio.